Amanda Reiman, PhD, is the manager of marijuana law and policy at the Drug Policy Alliance, where she works to develop the DPA's reform work as it relates to litigation, legislative and initiative drafting, campaign strategy, policy advocacy, media relations, fundraising, and public education at the local, state, and federal and international jurisdictions in which DPA is active. She joined the DPA in 2012 after working with Berkeley Patients Group, a renowned medical marijuana dispensary, as Director of Research and Patient Services, and she's a neighbor and a tremendous resource in this community where we're holding this event. Thank you, Amanda Reiman.
Thank you so much, Maria, and thank you all for coming. Everyone can hear me okay? No. Whoop.
Are you on?
She turned me on before I clicked myself in. Oh, wait, I turned off.
Yep,
There we go, now I'm on. I'm just going to leave this next to me. Okay, so now everyone can hear me, yeah? Okay, excellent. So I'm Amanda Reiman. I actually just left my position at the Drug Policy Alliance, so Ethan and I are in the same rowboat. But I'm now working as the head of community relations for a company called Flocana. That is a cannabis distribution company that works exclusively with our small organic farmers up in the Emerald Triangle. So I'm more than happy to speak about that with anybody afterwards. But what I'm here to present about today is my research life. So in my research life, one of the things I'm very interested in is the use of cannabis as a substitute for other things. And I kind of discovered this when I was doing my doctoral dissertation back in 2004, 2005. I'm a social worker by training, so I was very interested in the phenomenon that I was seeing happen in the Bay Area back in the early 2000s, where cannabis dispensaries really acted more as community health service providers. And so, it wasn't like a Walgreens, it was more like day camp. And you would go to a dispensary and they would have art on the walls, and they would have an event going on that night, and they would have support groups, and they would have access to free food. And one of the presentations before mine was talking about connection and the importance of connection in its relationship to healing. And that was something that a lot of these first dispensaries really provided for patients, was this feeling of connection. And so I was very interested in the feeling of connection that people get from cannabis compared to the feeling of disconnection that we hear people report from the use of things like opiates and alcohol. So when I did my dissertation research looking at the role that dispensaries played as health service providers, I asked patients if they were using cannabis as a substitute for something else. Now, the reason I asked this was because my own doctor, Dr. Frank Lucido, had been doing an extensive intake process for his patients for years, and it included that question. And he included that question because Todd McArea, psychiatrist here in California, was asking that question back in the 1970s. And so I really started to become interested in this idea of substitution as a harm reduction measure. So opiate use. Let's talk a little bit about where we're at with opiate use in the United States. So as we know, it has surpassed traffic accidents as the #1 cause of accidental death in the United States. In 2013, we saw over 16,000 deaths from prescription pain medication and 2,000 drug overdoses. Opioids specifically has rose 200% in the United States. Now, this is not a new issue. We have had the issue of overprescribing of medication for a long time. However, as I think was mentioned in the plenary last night, it's not until fairly recently that this issue has started to impact white Americans in the middle class. And since then, we have seen an increased vigor in which people feel that we need to attack this problem, including more research being done on exactly who this problem is impacting. So there was a study done by Castlight Health looking at the prescriptions for opiates in the United States and who was getting them and who was abusing them. What they found was that 32% of opiate prescriptions in the US were currently being abused, and that this was impacting certain people more than others. So I'll talk more a little later on about the impact of this on the older population, but baby boomers were 4 times more likely to be abusing these prescriptions. People with behavioral health diagnoses were 3 times more likely. Those with multiple pain conditions, as we know is very common for pain, were twice as likely, and those in the lowest income areas were also twice as likely. So we have a huge economic disparity in the ways that folks are being targeted by drug companies for the use of prescription pain medication. Now, interestingly, something else they found was that states with medical cannabis laws had lower rates of abuse on prescription pain medicine. But of course, this is not the first time we've noticed this trend. So when I was doing research for this study to publish this, I found an article from The Lancet from 1889. And it was called Cannabis Hemp as a Treatment for Opium Sickness. And the author went on to talk about giving hemp to patients of his who had opiate withdrawal and finding it to be an unbelievably successful method of treatment. So if we had picked it up then and ran with it, just imagine where we could be today. But of course, we know the forces of race and class and politics that did not want cannabis to become the choice for pain medication. I mentioned Todd McArea in the 1970s in California, talking about giving cannabis to patients of his who had alcohol dependence, seeing their outcomes get better, their lives improve once they're able to move on to cannabis. Then, of course, my doctoral dissertation in 2005, which has been replicated twice, once by myself in California and then once by Philippe Lucas up in Canada. And we found very similar rates of substitution across the board in all 3 studies. And we also found commonalities in the reasons in which people claim they're using opiates instead of, or using cannabis instead of their other medication, including less withdrawal potential from cannabis, less negative side effects from cannabis, and that cannabis was actually more effective at treating their condition than their other medication. Philippe may have talked about the top study that's currently happening in Canada, the Tilray Observational Patient Study, which is pushing this a step further by actually gathering longitudinal data rather than just cross-sectional data on what's happening to patients once they're starting to use medical cannabis instead of their other drugs, which is a huge step forward from where we are now. We're also starting to see a lot more research come out at the population level. So, for example, the Journal of the American Medical Association had a study that came out a few years ago showing a significant reduction in opiate-related mortality in states that have medical cannabis laws. There was a recent study showing a significantly less amount of Medicare Part D reimbursements in states that have medical cannabis laws. A study from RAND showed that states with medical marijuana dispensaries saw a 15 to 35% reduction in substance abuse admissions and opiate overdoses. And of course, there's the seminal work of Donald Abrams at UCSF looking at the efficacy of using cannabis and opiates together and finding that patients who were able to use these two together were able to use fewer opiates and were able to dose themselves with opiates farther apart, which reduces the likelihood of both dependence and accidental overdose. So, of course, we have a lot of evidence that shows that A, people are doing this, right? I think we can probably all agree now that this is a thing that is happening and that patients are choosing to do this for their own personal reasons. And we also see that at the population level, there's impacts of having medical cannabis laws on some of these outcomes. But we're still behind because of the barriers to doing this kind of research. So, of course, the Schedule I status, right? So until very recently, NIDA held a complete monopoly on all of the cannabis we could do for research. It's at the University of Mississippi. It's worse than the weed you got when you were 14 from the guy on the corner. It is not research grade by any stretch of the imagination. And recently, there's been some articles kind of highlighting this issue. NIDA has said that they are opening up the opportunity for other entities to apply for these licenses. Of course, we have not seen it be successful yet. However, the state of California is very interested in this because Prop 64 allocates millions of dollars a year to both the Center for Medical Cannabis Research at UCSD, run by Igor Grant, and for grants to the UC system to conduct public health research on the outcomes related to legalization. So right now, there's a bill moving through the legislature that would allow California to apply for a grant from NIDA for the Cal system to be one of the NIDA beneficiaries of cannabis for research purposes. So I think we are going to try to move this forward because that's been a huge barrier. And then, of course, the stigma around cannabis, which I'll talk a little bit more about, the beliefs about the safety of FDA drugs versus other drugs, which, of course, is a total racist and arbitrary line. But this still prevents doctors from learning about cannabis. It prevents patients from asking their doctors about cannabis. And it also prevents patients from fully maximizing the benefits of the plant because of the stigma that still exists. The legal uncertainty. So, even though we have medical cannabis, folks are still afraid their name is going to get on a list. They're still afraid that someone's going to take their children away because it's happening. So until there's absolute freedom for people to choose cannabis as a medicine without any of these worries, the research is going to be biased because the people that are choosing to use cannabis, despite all of these things, may be different than the general population. And then finally, the idea that we keep hearing resonate from our good friends at the federal government that using cannabis sends the wrong message. That apparently using a drug that has no chance of lethal overdose compared to one that has a pretty good chance of potential overdose is sending the wrong message. This is antiquated. This is reefer madness. This is propaganda. We don't even need to address this. We just need to move on, but to know that it's out there. So the current study. So I'm very excited. This is the debut of these data today. So this study is going to be published in the journal Cannabis and Cannabinoid Research. We're just finalizing the edits there. So this study was done as a partnership with UC Berkeley, Hello MD, and Kent State. So I'm the UC Berkeley, and then one of our co-authors was at Kent State, and then Hello MD is a service that provides telemedicine cannabis recommendations in the state of California. So you can go online, similar to other telemedicine programs. You can meet with a doctor over your smartphone or your tablet. You tell them what's wrong with you, and then they write you a recommendation for medical cannabis. Now, I know this sounds a little silly, but I actually used telemedicine the last time I had the flu, not even cannabis. And they looked in my mouth, and they looked at my arms and what was happening, and they said, okay, you'll be fine. And then they called to follow up. So it's not a totally weird thing nowadays to do telemedicine, but that's what Hello MD does. They have a database of thousands of patients, and that's really why I wanted them involved, because I wanted to be able to reach a lot of people. The goal of this study was to collect a lot of data. It was really to have a large sample of people so that we can start to look at things like gender differences, ethnic differences, so we can build on this, and other researchers can take some of these implications and then narrow in their focus to do additional research. So our methods, it was a survey research study administered online. The sample was drawn from the Hello MD database. Participants were entered into a raffle to win a Firefly vaporizer. We gave away 5. It really helped people fill out the survey. This was approved by Berkeley's Human Subjects Committee. All right, so some results. So the sample, we got almost 3,000 people to respond to the survey. So we had about 2,800 people. 55% were male. A lot of this is not surprising for anyone that's looked at demographics of cannabis studies because the mean age has been 40 forever. The mean age was 40 in my study in 2005. I think the mean age was 40 in like the replications of that study. That's just what it is. So I am the mean age of cannabis consumption right here, right now. 29% of the sample was over the age of 50. And 15% of the sample was over the age of 60. And that's definitely something we've seen increase over the past few years. 64% identified as white, 14% as Latino, and 7% as African American. So again, it's still a very white patient population. And then most patients had some college education or completed college at 71%, with 14% having completed postgraduate work. All right, this is really small. I apologize. I will tell you what it says. Okay, so this was about the conditions that they had and the method of ingestion they used to take in their cannabis. So 16% said pain was their primary condition. However, when we accounted for all pain-related conditions, so things like menstrual cramps, fibromyalgia, back pain, arthritis, that rose to 63%. So 63% of the sample was using cannabis for some kind of pain-related condition. The most common mental health conditions included 13% for anxiety, 9% for insomnia, and 5% for depression. Folks could choose more than one. So something I noticed from my previous research is that when you have a physical condition, especially a chronic one, there's almost always mental health that goes along with that. And one of the benefits patients get from cannabis is that they can replace their drugs for physical and mental health with just one thing, which is helpful. Smoking was the most common method of ingestion. 50% of the sample said that that's the most common way they use cannabis. And 31% reported vaporizing their cannabis, with 10% using edibles. All right, this is even harder to read. I apologize again. But I think everyone gets these slides, right? Yeah, I'll get these. So you can see. Oh, I'm being recorded. Okay, so we basically took these questions from the top survey that they're doing in Canada. So again, thank you, Philippe, for that. And again, I think it's great when you ask people the same questions because then you can compare samples. So I'm really hoping we'll get to do that. So we were basically asking folks if they were able to decrease the amount of opiates when they use cannabis, if taking opiates produces the same unwanted side effects, if cannabis has more tolerable side effects, if taking cannabis by itself is more effective than treating their condition, if cannabis produces the same amount of pain relief, if they prefer cannabis, and if they are more likely to choose cannabis to treat their condition if it were more readily available. So this is kind of the stigma question. Of the sample, 30%, so 841 people, had used opiates in the past 6 months. Okay, so about a third of the sample said, yes, I have used opiates in the past 6 months. Of this third, 61% of them said, yes, and I'm also using that with cannabis. Okay, so that's who was responding to these questions. So the strongly agree, I mean, I feel like I'm just like saying the same thing over and over again. It's working, okay? It's helpful. It has less side effects than opiates. And people think they have less withdrawal and they have a better experience. Now, something that's interesting to note is that even though only 71% agree or strongly agree that cannabis produces the same amount of pain relief, 92% said cannabis has more tolerable side effects. So even among people who say, you know what, the opiates work a little bit better, but I like the cannabis better because it's easier for me to take the cannabis. I'm less concerned about the cannabis. So they're almost willing to give up a little bit of that efficacy for the safety. And I think this is important because a lot of times we say that patients don't know about what they need. And we tell them what they need. And we get all authoritarian on them. And we say, why aren't you listening to me? I'm the expert. Well, you know what? Patients are really the expert. And I think this really helps us understand that patients know that there's a trade-off. And that they know that sometimes in an effort of choosing the thing that's going to be better for them long term, they may have to be ready to adjust in terms of the benefit in the short term. And patients can do that. And they're actually really, really good at it. 93% said they'd be more likely to choose cannabis if it was more readily available. Now, we also asked about non-opiate-based pain medication like Tylenol and Advil and ibuprofen. Because even though those things are often looked at as harmless, let me tell you, I have a friend who studies non-alcoholic related liver disease. Not harmless. Not harmless. And I think we have a society where people pop these things like candy, thinking that there's no outcome, and there absolutely is. So what we found is that 64% of these folks had taken a non-opiate-based pain med in the past 6 months, and 3/4 of them said that they used cannabis as well as that to treat their condition. So we see a very high rate of substitution and complementary behaviors going on with your Tylenol, your ibuprofen, your acetaminophen. So here we see that 96% of people say that they do not need to take as much of their Tylenol when they use cannabis, so they're able to reduce that amount. 92% says cannabis works better. 95% prefer cannabis. And again, 93% would be more likely to do it if there wasn't as much stigma. Okay, so some conclusions. So cannabis substitution for opiate and non-opiate based pain meds, it's happening. It's happening. We know that. It's happening. It's common. People say it works. People say it's effective. Pain patients report that cannabis works well as a substitute and a complement. And the stigma of cannabis is still an issue. So I did some other analyses, and I found that people of color were significantly more likely to report that they would use cannabis if it were more available. So the folks that could probably maybe benefit the most from an alternative to pain medication, because folks with lower incomes are more likely to have an issue, are saying that they're afraid to use it. And that's a problem. All right, so some more stuff to look into. So women were more likely to report past 6 months. Pain medication use, pain, I mean, everything related to that. So that I want to look into more. Whites are more likely to use opiates and use them with cannabis. As I mentioned, people of color are more likely to be impacted by stigma, and older folks are more likely to have a pain condition and to have used opiates. So what I'm really hoping is that we can move forward and help some of these people in the older generation move towards cannabis. So next steps, I'd love to compare these outcomes to the top study. I believe I'm looking at you. I'm also the scientific advisor for High Sobriety, which is a new a new treatment center down in Los Angeles that uses cannabis as a medically assisted treatment protocol. Folks meet with a psychiatrist. They get their cannabis 3 times a day, just like you would get anti-anxiety meds. And it's harm reduction. So the idea is we're moving people off of a lethal substance and onto a lethal substance, because I've known a lot of people who have died readying themselves for treatment. And then we want to do clinical outcome studies on them, because I'm tired of this cross-sectional, yes, patients say it's awesome kind of thing. And we need to move a step forward. And believe it or not, Kaiser's interested in studying this, and UCLA is interested in studying this. And folks are willing to think outside the box on this opiate thing. And maybe it's because white people are dying now, but you know what? It's an opportunity. It's an opportunity to really start this conversation in a serious way, not in a kind of like, ha, just give them a joint kind of way, but in an actual protocol for people who are suffering kind of way. So that's all I have, and I'm happy to take any questions. Thank you.
Hi, I have a question for you. I'm an LCSW, and yay, and actually, Haviland Hall, PhD.
Woo, me too.
Woo, me too.
Go Bears.
Long for you, though. Anyway, it thrills me to know the research you're doing. It was not exactly allowable in 1983. But anyway, so one of the things I've noticed, most of my clients are on Medi-Cal, and therefore the health provider is the community health clinics, which of course are overstaffed, underfunded, and just really hard and slow and difficult for a lot of things. And a fair number of them have lots of medical conditions where they've been on pain medications for many years. And a couple of years ago, it seemed like all of a sudden they were going in and wanting to talk about their pain medications, and they were routinely asked if they used marijuana. And when they said yes, they were told, well, we can't prescribe you anything. You have to go to pain management clinics. And it wasn't like on an individual basis about whether or not what they were taking, how, anything like that. I got the sense that maybe there was some kind of directive that came down, like from somebody, saying, okay, this is the standard protocol now with anybody requesting any kind of pain medication. If they're on marijuana, nope, they're a drug addict or might abuse this, therefore send them to pain management first. Do you know anything about that?
I absolutely know that it happens. I think a lot of it is really hit or miss, which is one of the problems with such the gray area around regulation, is that, some doctors are totally cool with it and others will send you right away and say, no, you can't have this until you come back and you're sober. With the legalization, we're hoping that now that cannabis is no longer contraband, that they maybe won't have a reason to deny medication for people that are using a legal substance for them as 21 and over. But the stigma is still there. And, unfortunately, the stigma is if you're using marijuana, why are we going to give you something that we can give someone who can keep themselves clean? It's the same reason that they deny organs to people that use substances. And so part of it is changing the policy, but a huge part is changing the culture.
You've been using the term cannabis a lot. Is anything in your work going to allow you to determine THC versus CBD with regard to pain?
So I'm really hoping that once we're able to do more controlled clinical outcome studies, we'll be able to look at the differences between things like THC, CBD, and how that impacts people. Right now, because it's self-report, it's mostly just cannabis. But we definitely want to get more differentiated in terms of strain and THC percentage and how that impacts effect.
I was just hoping you could clarify a point in your study protocol. So what I heard you say is that you conducted a survey on thousands of people who were using HelloMD in order to get the initial medical marijuana recommendation, and they told you all sorts of interesting details about how they use medical marijuana. But they use that service to get the recommendation.
So these are people that are already
place.
in their database. So these are current patients in the state of California. They're not people that have never used before. So we basically use the database. It's full of people that have accessed their medical recommendations through HelloMD. So they're all active medical cannabis patients in the state of California, and that's who we sent the survey to.
Hi. I was wondering if, so with opioid pain medication, you can see like tachyphylaxis over time, so it stops working. Do you know if there's any data on if cannabis, let's say, it works for 2 years, but then it like stops working, you have to use higher doses, dab all day? Is there any data on that?
Well, cannabis has a very short half-life. So even though it stays in the system for a long time, your tolerance drops fairly quickly. So we really don't see instances of people who need to consistently up their dose in order to get the same impact. However, there are definitely people who claim that the effectiveness changes over time. And this could be because of changes in the endocannabinoid system, because of changes in hormone levels. Once we understand a bit more about the endocannabinoid system and how it interacts with the phytocannabinoids, I think we'll be able to help people prolong that efficacy. But right now, I definitely hear folks who say, I used cannabis for 20 years and now it's not working for me anymore and I don't know why. But that's not different from other medications as well. So, but I don't see instances of people saying like with opiates, like one joint used to do it for me, but now I need like 5 or 6 joints. That we don't see as often. And Dr. Lucido does ask that question on his, I keep pointing at you because Dr. Lucido asked that on his intake form. Has your cannabis changed in the past year?
Thank you so much for your research. I too am a social worker. My name is Carol. I'm also a chronic pain patient who lives in Texas. For years, I didn't have access because I had to see a pain management doctor and do a UA. Luckily, I've been able to find a pain management doctor that gets upset if I do have a clean UA. But I am wondering if you're looking at topical uses, other types of uses, and more of a dosing schedule.
So the topicals, we did ask folks in the survey if topicals was one of the things they could choose as their preferred method of ingestion. We still see a very low rate of topical use as preferred method of ingestion, but as there becomes more older folks, I think we will see that rate increase. And that is the whole dosing. That's what I want to do with high sobriety. So when we're looking at a clinical outcome study, we know exactly how much they're getting, exactly what time of day, and exactly what dose. They're wearing things like heart rate monitors and stress monitors, and it's really going to give us that insight that we haven't been able to get otherwise.
Hi, congratulations on an excellent talk. I love your energy. I'm a pain doctor. In fact, I was the first fellowship trained one in Northern California, so I've kind of seen it from the beginning, and I want to address our first questioner's issues. About 3.5 years ago, there was something that came down. It's not a nebulous conspiracy. It's extremely intentional. And it was born many years ago out of an anti-advocacy group called PROP, who have been proselytizing non-scientific mythology about opiates and addiction And despite being laughed out of the FDA in 2009, they allied with the old war on drugs people and made it a political snowball. And they put out the information that nobody, no human organism can get more relief than is provided by, pick a number out of the air, 120 milligrams of morphine or its equivalent per day. That's wildly wrong. There's almost a 25 to 40-fold difference from person to person in dose response with opiates. And almost no health providers understand this. They've never had proper training in opiate pharmacology. And now we get into the era of pharmacogenetics. We find it's even wider than that. So the end result is we have a situation in California and most of the rest of the country where I'd say about 5 out of 6 doctors who are, quote, pain doctors have never seen the inside of a formal training program. There are people who got on a bandwagon in the 90s when Purdue Frederick and similar companies were marketing opiates rampantly and giving people the idea, well, yeah, it was very, very true that opiates were grossly underprescribed for decades. But then they went completely in the other direction. And the result is people have been overdosed, overtreated, and those of us who are properly trained and hopefully know which end of the reefer to light, we're overwhelmed. And at the same time, please understand, there are very active regulatory forces who are scrutinizing and trying to shut down legitimate pain management while injection mills and spinal pump implant salons are doing gangbuster business without any real surveillance. So
Thank you so
I
much.
could go on.
That's a really great summary. And in fact, we should invite you back to talk about that because that's really important information. But it is 6 o'clock. There is a celebratory dinner at 6:30. Amanda, you rock.